You guys are doing good. Okay, so on Friday we had some couple multiple examination MCQs for medical students arena. Today we are going to be very lucky because we are going to have discussion on clinical pathology. Actually, the we always have this basic routine, but sometimes due to time or other layout which are actually unscheduled, we tend to skip a day or two without any revision. So just as it is outlined in our timetable, we normally have some or live session with students. Now today on clinical pathology, just revise the MCQ that we had on the previous, that is last Friday. The first question is, according to what you can see from your end, which of the following is a marker for acute myocardial infarction? Myocardial infarction is cardiovascular related condition. So just like heart failure, just like angina, just like rheumatic heart diseases, or even valvular heart diseases, this is also something that handles or deals with the heart. So this question is just which markers are actually indicative of acute myocardial infarction. Different condition normally significantly are indicated by specific markers. Condition on the kidney, condition on the liver, we have to deal with some enzyme or something. If they are elevated up to this level, we know that this is acute myocardial infarction and not even valvular heart disease or ischemic heart disease. Okay, so hemoglobin, amylase, creatinine, and troponin. Hemoglobin is just component of red blood cells, which is actually important in transportation of oxygen. It binds to the oxygen, calls what we call oxyhemoglobin. Amylase, it's just an enzyme. Creatinine is also one of the metabolites which are actually extracted from muscle contraction and some metabolism in the body. Troponin is the correct answer. But then, let's see. In clinical pathology, specific biomarkers are used to detect tissue damage, including damage to the heart muscles in the context of acute myocardial infarction, commonly known as the heart attack, or AMI. The troponin is the most sensitive and specific marker. Hemoglobin, they all say, is oxygen carrying capacity of blood and is used primarily to diagnose anemia because we know that it ranges from female, based on gender, female ranges and male ranges. Normal parameters like for male start from 14 to around 18. But this again for female, hemoglobin normal ranges from 12 to around 14 or 16. So that is always used to diagnose anemia. We below 10 at most we normally have mild anemia, moderate anemia, and severe anemia. Okay, we'll check on anemia on that very day. That will also be able to be tackling anemia in specific. Talk about amylase is an enzyme that helps digest carbohydrate and is commonly elevated in pancreatitis. So when we have a condition of pancreatitis, and pancreatitis condition related to pancreas, when we have inflammation or inflammation of the pancreas, okay, this can be metabolic condition, can be just an uncommunicable condition, can result to significant sign on pancreatitis like inflammations, okay. So that is not always indicative in heart attack, but only in pancreatitis. Creatinine, these are marker of renal function and is used to assess kidney health. At most, let me tell you, for kidney failure, we need creatinine evaluation for us to know the level. If not creatinine, we can use what we call the glomerular filtration rate to give us what is the level of the failure. Okay, yeah, we have acute kidney failure, we have chronic renal failure, all that one. So based on the level of creatinine, some people talk about 50% of the creatinine indicator for that, but we'll check on that when we're actually handling on the condition related to renal. Okay, troponin specifically cardiac. We have troponin I and T. So it's released into the bloodstream when the heart muscle is damaged. It rises within 3 to 6 hours of myocardial injury and can even remain elevated for 7 to 10 days. So it is currently the gold standard biomarker for diagnosing acute myocardial infarction due to its high sensitivity and what we call specificity for cardiac tissue only. So that's the gold standard. We check on the troponin and then you get to know that. Okay. So that is that. Number two, in which condition will you expect to find microcytic hypochromic anemia? Now, anemia is classified basically multiple times differently due to either etiologic, due to how they present. Okay, and you see, anemia is something to do with red blood cells, the hemoglobin in red blood cells. Now, this is the thing. You know very well that red blood cells are responsible for transportation of oxygen and carbon dioxide, those gaseous exchanges, respiratory gases. Okay, so if we have hemoglobin in terms of whether low in number or or small in size, they'll give us some indicative anemia, and that is how we are going to classify anemia based on those specificity. But again, let me tell you something here. Anemia can also be classified based on what we call causes. We have aplastic anemia, we have iron deficiency anemia, we have hemolytic anemia. All those ones are just types of anemia. But then, based on the hemoglobin, we normally talk about things to do with macrocytic hyperchromic anemia, microcytic hypochromic anemia. So you get to know all that. So what I want to tell you that anemias are caused based on red blood cells size, the RBCs, you know them. So red blood cells can have what we call MCV, or what we call the mean corpuscular or corpuscular volume (MCV), and hemoglobin content. Hemoglobin content is what we call MCHC, or mean corpuscular hemoglobin concentration. So in microcytic hypochromic anemia, I've said micro, small, hypochromic, pale in a way. The RBCs are smaller than normal and contain less hemoglobin, making them pale in color. Now, if the RBCs are smaller than normal, it means that with the size reduced, there'll be very many within that given amount of blood. When something is small, the size it now occupy less space, and therefore within a given field, there will be very many. But now the content, they will contain less hemoglobin because of their small size. With less concentration of hemoglobin, we'll have pale in color. So pale in color is what we call hypochromic. Now, I wanted to know that when we have microcytic hypochromic, small and pale, that is always caused by iron deficiency anemia. So we will get to even know when you interpret your full hemogram, yeah, and you get MCHC low. RBC can be normal or even above slightly or towards the upper limit, but then MCV can also be a bit less because MCV is direct, I mean, in terms of the size of the RBC. So low MCV, low MCHC, sometimes even the hemoglobin themselves are also low. That one talk about microcytic hypochromic, okay? And vice versa, macrocytic hyperchromic becomes the case. Now, when we talk about the first choice, that is polycythemia vera. Polycythemia vera Polycythemia vera, these are what we call the myeloproliferative disorder, characterized by increased red blood cells mass, not anemia, okay? So it's a condition of red blood cells, of course, but you realize that there are very many red blood cells because they're multiplying at a very, very cancerous speed. So even their mass also increase. So with that, it doesn't have anything to do with hemoglobin, so it cannot be anemia. Talk about the RBC. The RBCs are usually normal in size and color, but are produced in excess in polycythemia vera. Okay, so they realize what we call hyperviscosity of blood, very thick blood. You take it navakitin and you realize the blood is so thick. Okay, you may need to check on polycythemia vera. Hemolytic anemia is involved destructions of, I mean, RBCs. Okay, typically leading to normocytic normochromic anemia, because when there is destruction of red blood cells, we will just get something to do with okay, they are destroyed and they're killed and they're gone. So there's nothing which is interfering in their shape. So what we'll get is the normal size and the normal concentration of hemoglobin. So we talk about normocytic normochromic anemia, and the cells are normal in size and color but destroyed prematurely. It is not associated with microcytosis or hypochromia. Sickle cell anemia. This is a normocytic anemia caused by abnormal hemoglobin. It's more of a genetical condition. So it leads to sickling of red cells under stress, called abnormal hemoglobin given by HbS. Okay, the RBCs are not microcytic or what we call hypochromic, but instead they become crescent shape and less flexible. Talk about iron deficiency. This is now the correct answer, and this is the classic cause of microcytic, that is small and hypochromic pale anemia. Iron is essential for hemoglobin synthesis. Without enough iron, RBCs are produced with less hemoglobin and are smaller in size, so it is commonly seen in chronic blood loss, poor dietary intake, or what we call malabsorption. Malabsorption can also be due to alcohol intake, which will interfere with receptors in your stomach, which are relatively important for absorption of dietary elements. Now, conditions mostly closely associated with microcytic hypochromic anemia, they are always because of iron deficiency anemia. Question 3. What is the primary function of the red blood cells? That's a very simple question you started studying in class 2. So, what is the primary function of the red blood cells? Digestion, transporting oxygen, immune response, coagulation. Of course, he's transporting oxygen. There's nothing here there. I mean, primary function of red blood cells, erythrocyte, we can call them, that is transport oxygen from the lung to the tissue and carry carbon dioxide from the tissue back to them. So the function is made possible by the presence of the hemoglobin, as I told you before. That's just a red pigment rich in iron that has high affinity for oxygen. Digestion, no. This is carried out by gastrointestinal system, not red blood cells. Transporting oxygen, that is very correct. Human things to do with immune response, that's the role of white blood cells, the leukocytes, okay? Coagulation, platelets, or what we call the thrombocytes, or clotting factors and all that. So therefore, the primary function still remain to be eaten. Which blood type is considered the universal donor? That is, everybody knows. Oh, why? AB is the universal recipient. The recipient. So the term universal donor refers to blood type that can be safely given to individual of any other blood type in emergencies, especially when there is no time to perform cross matching. So, blood type is determined by the presence of or absence of antigen. Antigen A and B, when they are absent, we give blood group O. Okay. So, type O, no A and B antigens on the surface of its red blood cells. So, it won't trigger an immune reaction to any recipient. That's why it's a donor. Type A and anti A and anti B antibodies in plasma are missing, but this only matters when all blood or plasma is given. For red blood cells transfusion, the absence of A and B antigen is critical factor. So, hizo antibodies na zingine, they are not important. Now, let's check the first question. AB, if you have both AB, it means that you will be rejected by some of with the blood group with anti A or anti B. AB is actually the universal recipient, not donor. You can accept everything because you don't have antibodies to react, but you cannot be admitted. Your blood AB cannot be given to anyone. Actually, not to anyone but to some, not to everyone. Okay, so blood group A contains A antigen and anti B antibodies, which limits compatibility. B contains B antigen and anti A antibodies, also not compatible with all our blood group. So the correct one is type O. Red blood cells have no antigens, neither A or B, making them compatible with all the types. Type O negative is especially known as the universal donor in emergency. Okay. Yes. Number 5. What is the normal range of fasting blood glucose level? Fasting blood glucose, if you want to diagnose diabetes mellitus, we check on the blood sugars. So these are blood glucose levels. So we can measure them in millimoles per liter or milligram per deciliter. These units normally confuse people. Please know either way. Now, what are we measuring? We have almost four types of measurement that are investigative techniques that are used. It can be fasting blood sugar, it can be random blood sugar, it can be glucose tolerance test, it can be glycated hemoglobin. Okay, so fasting blood glucose refers to the level of glucose in the blood after an individual has not eaten for at least 8 hours. It's a key screen tool for diabetes mellitus and other disorders of glucose metabolism. So, for example, okay, so 140, let's check on the choices. So, 140 to 180 milligram, this is abnormally high. A fasting blood glucose level in this range suggests poorly controlled diabetes or hyperglycemia is not within the normal range. 70 to 100 milligram per deciliter, correct answer. This is the normal reference range of fasting blood glucose in a healthy individual. Values in this range indicates normal glucose, hemostasis, and pancreatic insulin function. But above that one, it's very indicative you are diabetic or hyperglycemia. 100 to 140, this range falls into the category of impaired fasting glucose, IFG, or prediabetes. Individuals in this range are at risk of developing type 2 diabetes if preventive measures are not taken. Then 50 to 70 milligram per deciliter, this is considered hypoglycemia, low blood sugar, which can cause symptoms such as dizziness, confusion, sweating, and even loss of conscious if severe. So, normal fasting glucose 7 to 100 milligram, pre-diabetes 100 to 125 milligram, diabetes 126 and above. Therefore, the correct one, therefore, range in fasting blood sugar or glucose range is 70 to 100 milligram per DL. Number 6, high level of which enzyme is associated with liver damage or disease? Lipase, creatinine kinase, alanine aminotransferase, and amylase. This one you need not to fail. These are simple thing, Bana. You guys, which book are you guys reading? ALT, SPOT, those are for liver, okay? So that is that, and we're going to proceed like that. So that's for liver. So the correct answer is ALT, alanine aminotransferase. Alanine aminotransferase is a liver enzyme that plays a role in amino acid metabolism. It is found primarily in the liver, and when liver cells are damaged or inflamed, just like the way you say troponin is in the cardiac, so this is also found in the liver. So LT is released into the bloodstream, making it a highly specific marker for liver injury. So lipase, an enzyme, help in digestion of the fats, mainly produced in the pancreas. Okay, so elevated lipase levels are indicative of pancreatic inflammation. Creatine kinase is also skeletal muscle and cardiac muscles and the brain. So if you get CK, it is elevated in conditions such as myocardial infarction. That's still the same with the heart. So CK and troponin are the same. What we call the rhabdomyolysis and muscle dystrophies also can give us that. So it is not specifically to liver. Alanine transfer to the correct answer. It's highly concentrated in liver cells, and elevated levels are common seen in hepatitis, liver cirrhosis, fatty liver disease, alcohol-induced liver injury, and drug-induced hepatotoxicity. So it's one of the most reliable enzymes for assessing liver function injury. Amylase, like lipase, amylase is also produced by the pancreas and salivary gland. So it helps digest carbohydrates, and it's elevated in pancreatitis, but it's not indicated liver damage. Okay. In conclusion, LT is strongly associated with the liver cell injury disease and inflammation. So that is that. Going to the next page. What is the primary function of the liver in carbohydrate metabolism? A. Protein breakdown. B. Glycogen storage, lipid synthesis, and gluconeogenesis. Okay. So, okay, the correct answer here, I know you knew it. Gluconeogenesis. We don't break protein there. Glucogen storage, okay, but that is not primary function. So let's check. Check this one. The liver plays a central role in carbohydrate metabolism, helping maintain blood glucose level within narrow range. Among its several metabolic functions, we have what we call gluconeogenesis, particularly crucial during periods of fasting, starvation, and intense exercise when glucose index is low. Protein breakdown, these are primarily associated with the muscles and other tissues. But the liver deaminates amino acid and convert them into glucose via gluconeogenesis. Protein breakdown itself is not liver primary function in carbohydrate metabolism. We are talking about carbohydrate metabolism. We are not talking about protein. Okay? So glycogen storage, the liver does store glycogen. This function is important for short-term glucose supply. However, this is not the liver's primary role in carbohydrate metabolism. So it is storage function, not dynamic regulatory one. Lipid synthesis relates to fat metabolism. The liver does synthesize lipid, including cholesterol and triglycerides, but this has more to do with lipid metabolism, not carbohydrates. Okay. Then gluconeogenesis, the very correct. This is the primary liver function in maintaining blood glucose level during the period of low carbohydrates intake of fasting. Gluconeogenesis is the generation of glucose from non-carbohydrate sources such as amino acid, lactate, and glycerol. So this process is vital for supplying the brain, red blood cells, and renal medulla with glucose when dietary intake is inadequate. While the liver also stores glycogen, and the primary active role it plays in carbohydrate metabolism, especially during fasting. So correct answer is gluconeogenesis. So which of the following is common marker for kidney function? We had already discussed this one and you know it. Troponin, we had said so that is for cardiac muscle. Blood urea nitrogen, wow, that's good with liver, okay? Creatine kinase also there, but now if burn is here, then creatinine comes secondary. Aspartate is not there. So the correct answer here is blood urea nitrogen, the burn. The kidney play a key role in filtering waste product from the blood. One of the most common laboratory markers used to assess kidney function is what we call the burn. Burn reflects the amount of urea nitrogen in the blood, which is a waste product from the breakdown of protein in the liver and excretory. So troponin is a cardiac marker used to diagnose acute myocardial infarction, the heart attack. Blood urea nitrogen, correct answer. Burn is commonly used in conjunction with serum creatinine to evaluate renal function. So elevated burn levels may suggest impaired kidney function, dehydration, or high protein intake, however. So creatinine, but one thing that I need to tell you, burn alone is not specific, so it's often interpreted alongside creatinine. So creatinine kinase is this is the enzyme found in muscles and the heart, and it's elevated in muscle injury, like rhabdomyolysis, myocardial infarction. It's not kidney function marker. Talk about aspartate. This is likely referring to aspartate aminotransferase, an enzyme found in the liver and heart. It is marker for liver damage, not kidney function. Conclusion: the most appropriate one and commonly used circuit that is banned. Elevated levels of which blood lipid are associated with an increased risk of heart disease. Elevated level of which blood lipid are associated with? But anyway, it's in LDL. This is very easy. Cholesterol, no. It's okay. You can argue on that, but it's still under the low density lipoprotein. Triglyceride and high density lipoprotein. So get me right. The correct answer here is low density lipoprotein. This is because commonly referred to as the bad cholesterol, because elevated levels are strongly associated with an increased risk of atherosclerosis, that is the narrowing of the blood arterioles. Okay. Coronary artery disease, that is blockage of the blood supplying cardiac with fatty plaques, and even other cardiovascular conditions such as thrombosis and etc. We have coronary thrombosis. So cholesterol is a general term for including both good and bad. Yeah, while total cholesterol is important, type and ratio that matter most in cardiovascular risk. High total cholesterol may or may not be dangerous depending on LDL and HDL. So low density lipoprotein correctly is the correct answer. Why? The LDL carries cholesterol from the liver at the arteries. If there are too much LDL can deposit in the artery while forming plaques that narrow and stiffen artery, a process called atherosclerosis. These increase the risk of heart attack, stroke, and peripheral vascular diseases. Triglycerides, these are another type of blood fat, okay, and high level are also associated with heart diseases, especially when they combine with low HDL or high LDL. However, LDL remains the most direct and well established risk factor. High density lipoproteins, these are good cholesterol, okay, also remove excess cholesterol from the bloodstream and transfer to the liver for excretion. So HDL levels are protective against heart diseases, so LDL is what we normally check in. The last question: which of the following is not a primary function of the kidneys? Excretion of waste product, filtration of blood, production of insulin, regulation of blood pressure. Excretion of waste products, filtration of the blood, production of insulin. Which is the function of the kidneys again? Correct answer is production of insulin. I don't know even why I was thinking. The kidney are vital organs from with multiple essential what you call physiological role, but insulin production is not one of them. Let's analyze the function listed. Excretion of waste product, primary function. The kidney removes metabolic waste products like urea, creatine, and drugs from the bloodstream through urine formation. Then talk about filtration of blood, okay? Primary function still. The kidney filter around 180 liters of blood daily through structures such as nephron, you know them, removing toxin and maintaining yourself. Production of insulin, not that is not fun. Actually, insulin is being produced by the beta cells of the pancreas in the islets of Langerhans. I hope you remember that one in biology form too. So its role is to regulate blood glucose level by promoting the uptake of glucose into cell. The kidney do not produce insulin. Primary function: the kidney regulate blood pressure via the renin angiotensin system. We discussed it the other time. Fluid volume control through sodium and water balancing and vasoconstriction mediated by hormones. So correct thing is that the kidney perform neurovital function, but insulin production is not one of them. So that is the correct answer: production of insulin. Thank you so much. I think that is how we finish it. Yeah, you can get this on the YouTube.